Pulitzer Prize-winning author Tracy Kidder, who once wrote a book about Paul, described him as, quote, a man who would cure the world. Paul Farmer has dedicated his life to treating some of the world's poorest populations, in the process helping to raise the standard of healthcare in underdeveloped areas across the world. Paul is the founding director of Partners in Health, an international organization that provides direct healthcare and services and undertakes research and advocacy activities on behalf of those who are sick and living in poverty. In this role, Dr. Farmer and his colleagues have successfully challenged policymakers and critics who claim that quality health care is impossible to deliver in resource-poor settings. In Haiti, where Paul began working in 1983 as a student, he helped pioneer treatment of both multi-drug-resistant tuberculosis and HIV, which was key in helping Haiti qualify to be the first country in the world to receive financial support from the Global Fund to fight AIDS, TB, and malaria. He's since helped expand the Partners in Health model to 10 countries around the world. Trained as a medical anthropologist, as well as a physician, Paul spends a good deal of his time not just shining a light on health inequities, but explaining how much we could do to address these challenges. The first time I had a chance to meet Paul and hear him speak was at the Gates Foundation about 5 years ago. We were a lot smaller then. And what I remember most about his talk was how compelling he spoke of health as an issue of social justice. I was also taken by how seriously he took his role as an advocate for the world's poorest. He's one of the most outspoken and effective champions for global health, which he said he feels is a part of his responsibility as a physician. Paul's uniqueness also lies in his ability to captivate audiences through storytelling about issues and challenges that to many audiences might otherwise seem a world away. On this, he said, quote, "It's only a failure of imagination that people turn away. The poor are doing their job. They're shouting as loud as they can. It's we who can't hear them." Please join me in welcoming Paul Farmer.
Thank you, Joe. Thank you, Teddy. Thank you. Thank you very much. I'm going to switch on this device. I live in fear that these devices will be on when you don't want them to be on. I didn't know that there'd be so much focus on tuberculosis tonight, nor did I know that you'd be using that clip. But I like to use levity when I feel emotional. Does anybody else do that? I think that's a very common trait. I felt emotional just when I walked in this room and saw the tables with the names of all these countries on them. That just shows how cheesy I am. But I will tell you that, and thinking about what Susan said earlier about the risks that people take in this work, I told the scientists this morning that there was a joke at the Harvard Teaching Hospital where I'm lucky enough to work. So I've been going between Harvard and Haiti or Harvard and wherever, Rwanda recently for many years, 26 years, but who's counting? And when I was training, and I have asthma and have for a long time, and I later heard that the students and the interns and residents used to say, when Paul Farmer talks, people listen. When Paul Farmer coughs, people run. So there is a downside, back to your point, there's the risk, but there's also, everyone kind of flees. I am going to talk about tuberculosis, and I was invited to think about, I was asked actually, what is it that inspires you to do your work? And I always feel uncomfortable giving those kind of talks, because after all, it's not really about me or even anyone in this room. It's about the people we're trying to serve. And again, that sounds formulaic, but it's how I feel and how many of you feel. I just said to one of the members of the board, to me, looking out at this room, it's very moving because there's so many people here. This is a very special city, and SBRI is a very special institution. But there are changes happening in this country and in others around that relate to global health and that make the work that I have to do much easier. And my focus tonight, and I'll be very brief, I should be done by about 10:30. Actually, I'm told that if I really meant that, there would be serious rioting in the room. As you know, I want to speak on behalf of myself and also Jim Kim, who's being honored. And actually, Jim's sister Heidi is here. And I want to talk about, I want to respond to the invitation to talk about what inspires me and tell stories, as Joe just said. Although, where'd Joe go, by the way? He's sort of our movie star of global health. Forget about Brad Pitt. It's true, narratives are important. And sometimes people dismiss the importance of stories, especially people who are teaching in universities. But I'm not going to do that. I want to explain why I think the work of SBRI is so important. I'm on the delivery end of this, working in the field, working with patients, working with people who are sick. But we have nothing to offer unless we have the fruits of basic science at our disposal. And if you look at tuberculosis, and David said this beautifully, I thought, here we have 2 billion people in the world infected by the organism that causes tuberculosis. So it's the most cosmopolitan, common infection that there is, practically. We have millions of people falling ill every year and millions dying. And we haven't had new therapeutics, that is medicines, in decades. The diagnostics we use, and I swore that tonight I would avoid any jargon, but the diagnostics we use are also about a century old, the ones that people like me have available to them in places like Rwanda or Haiti, and we don't have a vaccine. So we have to make do, as Joe said, and as was mentioned in the little clip, we have to make do with old meds, no vaccine, and poor diagnostics. And we're just the intermediaries between science and the poor. So I wanted to make this vivid, not by giving a speech, but by telling the story of what really inspires me, and that is when things go well, when things get better. All right, now I've been told, I got briefed so much on how to use this stuff that it made me nervous. Let's see if I can do it. So this is the reason I'm going to tell you this story, and it'll be brief, is because I know the ending, and it's a happy ending in many ways. But this child, and I noticed that a number of people here have read Tracy Kidder's book about our work. And people came up to me and said, "Oh, I read your book." And I've made a joke several times today. I said, "Oh, really? Which one? Women, Poverty, and AIDS?" And then everybody laughs because no one's ever read my books, which I might add is very annoying to me. So for those young people who actually brought my books to sign, thank you. But anyway, in Tracy Kidder's book, in the paperback version, there's a picture of this kid. It was taken by someone who was then a student of mine, and she's not a photographer. It wasn't even a great picture, but this kid was adorable. And some of you, everybody here can see that and I know that about 2/3 of you are not scientists or practitioners, but you don't have to have a PhD and whatever to see that this child is wasting away from what used to be called in the old days a consumptive illness. And the reason I use his case is not because I remember that picture was in Kidder's book, but because here is someone, his name happens to be Al Conte, his real name, who has a disease that's killing him, which it was killing him. Fortunately, as I told you, that process was arrested, and no one can figure out what's wrong with him. And the reason that was the case is because we do not have a diagnostic test for tuberculosis that is, and I'm not going to use any jargon, don't worry, that is specific and sensitive. And in lay terms, either it misses too many cases or it gives you too many wrong answers. That's good enough to know. So this kid already went through the standard tuberculosis workup and couldn't be figured out what he had. That's because he did not have tuberculosis in his lungs. He had it outside of his lungs. Anyway, it shouldn't be rocket science. But the good news is, because he came into a facility where even though we didn't have the diagnostic tests because they don't really exist in places like this, we did have the experience to figure out what he had. And again, to be a little bit rhetorical, because this is a good case for teaching students as well. If a child has tuberculosis, which is an airborne disease, you can bet that he got it from one of two places, or she got it from one of two places. And that's where are the two places children go: school and home. And it turns out that this child, like way too many children, was not in school, which is something we did not discover until he became so ill that he ended up in the hospital. Anyway, the sort of Paul Farmer coughs, people run part of the story is, it had to be, I'm glad some people are laughing at my humor, because even though that the work that we do is sometimes a downer, it's also very exhilarating. I was at a few months ago, and I just told some students who were part of the SBRI program for students, I just told them that I had been at the University of Texas, San Antonio just recently, and a medical student came up to me and said, "Oh, Paul Farmer." And I thought he was going to say, "Really love your work, going into global health, going to do research in tuberculosis." I thought he would say something nice like that. And he said, "Oh, Paul Farmer, I thought you'd be a grumpy old man." To which I responded, that's not a usual opening gambit, by the way, for a guest lecturer. So I said, "Oh, really? Why is that?" Just like that. And he said, "Because I've read your books." To which I had to say, "Yeah, I know, you're right." So anyway, the point I'm making here is that this is sometimes sad stuff, but it's also can be very gratifying work. As the scientists who are driving this agenda forward at SBRI know, they've got their eyes on the prize. So for this child, if you look closer, and it's his mother in the background, you see that he's got something in his neck. And, these are such huge lesions. A lot of people who saw him in our network said, "Oh, he must have, cancer, lymphoma." And actually what those are, I'm sorry, I'm embarrassed to tell you that we gave him that scar, because in a way, probably it wasn't necessary to do all this. The reason he has a scar in his neck to this day is because we didn't have the tools to diagnose this properly. That's what SBRI is working on, giving people like me on the delivery end the tools we need. So we went through, most children, of course, with this problem would just be gone. But I have to say, I'm embarrassed about the scar, but we really fought hard to figure this out. And of course, as everybody here knows, he had tuberculosis and was put on therapy even before we had the results from this biopsy. But then again, back to the question of where do you get this? I told you he wasn't in school. And so what we do, usually not me, but our staff, is to do home visits. And I'm going to close in a minute, in about 2 hours, by mentioning our delivery arm. Did someone really hiss when I said 2 hours? I'm just kidding. So we went to the house, and this is what we found. And you would not believe how many people were living in there. And I said, "Why don't you come back here?" By the way, my favorite thing about working in Haiti and later in Africa is T-shirts and hats. He has a Zebco fishing rod hat on. That's my favorite part. But now you can see this bright-faced little boy is already halfway through treatment here in this picture. And there's his mother, and there's his father, and 3 of his siblings, and there were a whole bunch of them. As we say in scholarly terms, a whole passel of them. A friend of mine here is from Alabama. That's how we say it in Alabama, a whole passel of them. But I would ask you, lay people, non-doctors, which one of the parents looks sick to you? Yeah, it looks like the father. And again, it's not rocket science. And so I said, as doctors do, take off your shirt. And he did. And then this is months after this guy is walking in and out of the ward to see his son. And of course, we I guess one of the points I'm making is we don't have the diagnostics, and these delays cause problems. They cause people to die, of course, but they also cause, as David mentioned, ongoing transmission of tuberculosis, including in hospitals, which is a huge problem globally. And then for those interested in the clinical part of it, so this is just a digital photo of his X-ray. All right. So there you have it. For those of you interested in such matters, obviously, as everyone at every table knows, Greece. I'm kidding. You don't even know you're at the Greece table. Wouldn't it be bad if I were at Harvard, I would call on people and say, "You, what's the diagnosis?" I won't do that here. Ken would never have me back. Anyway, this is an obvious and a whopping case of pulmonary TB, and that's the father who's been coughing in this miserable little place, this hut, and he has a whole bunch of children. About half of them, we thought, had active tuberculosis. Now, the good news, just to end up, is so what do you do then? And this is a big struggle for everybody in global health. And I don't want SBRI to start worrying about housing conditions in Haiti. I want everybody in the labs to stay in the labs. Don't come out. The people in this room have helped build you good labs. Stay in there and get us the vaccines and medicines and diagnostics. And we, on the outside, are waiting for those tools. We're waiting to have the things we need to deliver. People need better housing. You can rebuild housing. Here's a picture of me about to have a heart attack after walking to this place. Never mind. And then I will need care for my coronary artery disease. And here's one of the reasons I wanted to show this story. So here's the kid after treatment. I mean, come on. But wait, yeah, no, it's but there's more to the story, and there's more to his story, which is the story of so many people with tuberculosis. That's maybe what I said. I think the picture was taken in 2000. So that's 9 years ago. But the good thing is, and then I forget. Once they get better, I forget about them. I can't be blamed. You laugh. I mean, Rotary forgets about people when they're done with the vaccinations. So this is this sunny smile I won't forget. But then about a month ago, and then someone asked me in January. Jim and I were teaching a class together at a small community-based college in Cambridge, Massachusetts. And anyway, so we're teaching a class at the Harvard School of Public Health, and we were doing case studies. This is the latest obsession. I'm sure you guys are all going to have to do them. And I was teaching him about Haiti, and a student who was a medical student afterwards said, "Paul, you're always going on about how difficult things are in Haiti. You've been there for 26 years. Aren't things any better?" And he said that in an accusatory fashion. Maybe I should come teach in Seattle. He said in an accusatory fashion. It was after class, so I have to give him that. So I said, well, yes, they're better. And he said, well, what data do you have to show that? And I said, let me just tell you a personal story. I said, I went there in 1983, and people were working in a squatter settlement. Actually, some people from this area, from this community, have been there to visit. I won't mention them. They have a small foundation here. And anyway, so I'll have to tell them this story too, because they're always asking about metrics. But here's one metric. So in I think he's laughing. I'm actually not from Harvard. I'm from McKinsey. Anyway, so here's a metric that I liked, and I told this student in our class. I said, when I went there the first time, I was 23 years old, to this particular squatter settlement, and people were saying, we're hungry, we have no food. And now, 25 years later, instead of having people say, we're hungry, we have no food, I get nasty emails from the village saying, Paul, you promised us Windows XP. Where is it? True story. It is a true story. Anyway, So I'm not sure Jim Kim was listening to this conversation, but that's what I told his student. This was just in January. But this kid is this is one of the reasons I wanted to tell the story. So a month ago, who should I get an email from but him? An email. And just to prove it to you, he sent me a photograph of himself, as one does in all these places. And there, 2009. So that's the end of my... That's not even the picture I wanted. But now he's a grown-up. So again, I ignore them when they're grown up and well. But I just wanted you to know. What is his, as we say in medicine, what's his chief complaint? He wants to finish school. And to bring this back to SBRI and why I'm here tonight is we have the capacity to think about how to deliver the services. We're not there yet. We still have lots of challenges. And I want to make a little tribute to Jim Kim. I don't have before and after pictures of Jim Kim. What? That's his sister. Actually, I'm trying to keep her on her best behavior because she knows way too many things about me and Jim and all of us. Behave. So Jim Kim, I think if he were here with me tonight, he would be talking about the challenge of delivery. And how can we be good partners to groups like SBRI? And that is to think about how we're going to implement, how we're going to use the tools that come, in my view, from basic science. Meaning there are many sources of information and new tools. But for medicine and public health, if you ask me, the main font of tools has been basic science. So, but when we have new vaccines and new diagnostics and new therapeutics, those are the three classes that we should think about is vaccines to prevent. We're going to need to have good health systems. Now, I don't think, as I said, don't bring the SBRI people out of the lab. Let them do what it is that they could do best. But we need a team to think about all of these Ds, if you will. And here I really am going to close. And I just made this up. I didn't run it by SBRI, but I was thinking about. No, I didn't. I hope they like it. Do you like it? Where's Ken? I think I got a thumbs up. So the 3 Ds, there are a million ways of looking at this, but the way that I would find useful, and people of Seattle, I sound like, what is that guy's name, Stephen Colbert? Is his name really Colbert? Doesn't he say people? I don't have a television, but I do have a computer, and I do have Windows XP. But people of Seattle, you should be very proud of what has happened in this city. And I was bragging that a few years ago, if you look back to your local papers, I forget which one. There used to be 2 of them. Sorry. Is that a bad? Sorry. Can you strike that from the tape? Anyway, if you look back to your local communication devices, some years ago I was here. I think it was maybe even the talk that Joe mentioned. I was at the foundation. By the way, that's what we call it outside of Seattle also. The foundation. It's like the CIA being called the firm. I think it was on that visit, and there was some newspaper articles, and I was saying, look, I think Seattle is going to become the hub of global health in this country and the world. And I hope that what Ken has been calling the community, that is the people of Seattle, from the business community, from the foundations, from the universities, are proud that this city has helped to put global health on the map, and are proud of the fact that if you look at the late 20th century, which is when I trained in medicine, and many of the people who are senior researchers now trained, this city and a number of institutions based here really performed, as I put it this morning, and Ken said you're allowed to say that time, performed CPR on international health. This was not a field that was growing. It was not drawing young people. It was not drawing students. It was really a hangdog kind of depressed field. And you can't rebuild something without investing in it. And I just think that here, in this city, people have been thinking about discovery from basic science, about developing new products, and really also about delivering the services. And that's what we need to do. Right? Too often in a research university, and I won't mention anyone by name, but I work with one of them, there's a focus on research and training, but the service part gets too slender. And it doesn't matter who is doing the service part, it just matters that it be done. And that's what I think we can build together when we have the right kind of investments in basic research, getting the tools that we need to take care of the people we're serving. We'll find ways of delivering them that are acceptable to the people we serve and also impressive to those who would support this work. I think that we are on a path towards real progress in global health, not just in building a field of global health, but in actually reversing a lot of the what were called emerging epidemics today, and in building on, to think again about Rotary, and building on the successes of some of the more specific programs. That's where I think we're headed. And as you can imagine, there are a lot of people waiting. And that's my last image, is from a beautiful brand new hospital we just built in Haiti. And a lot of people there are waiting. So thank you all, and thank you. I know Jim would thank you, and good luck, SBRI.
It really gives me the greatest of pleasure to present to you and to Jim Kim the Advancing Global Health Award from SBRI. This is our highest honor, I should point out. And this is for the work that you and Jim have done in your Partners in Health program. And we now feel that we've cemented this partnership even further and look forward to the days when we can be bringing you the tools that you need to bring to the people who need them. So thank you so much.
Thank you very much. Thank you very much. Thank you. It's a beautiful, beautiful image. Thank you.